Good afternoon, everyone. My name is Shannon Kepka, and I'm a project manager working with the nursing home teams in New Mexico from Health Insight. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They're brought to you by the New Mexico Statewide Partnership to Improve Dementia Care Work Group and sponsored by the New Mexico Department of Health, New Mexico Healthcare Association, and Health Insight. So we are very excited about today's presenter, who is returning to us after doing a great presentation on Lewy body dementia last month. Dr. Janice Knoefel is a neurologist and geriatrician with 35 years experience. She is trained in internal medicine, neurology, geriatric neurology, and public health. She's been on the faculty of the University of Cincinnati, Boston University, and UNM, where she's professor of medicine, geriatrics, and neurology. She participates in clinical care, teaching, and research. She's interested in neurological diseases of aging, most importantly, Alzheimer's disease and dementia of all types. She's the clinical director of the Memory and Aging Center at UNM's Clinical Neurosciences Center. All right, Dr. Knoefel, you may get started.
All righty, thank you so much, and Shannon, thank you for inviting me again. I love speaking about sleep because it's one of my most favorite things, and I hope that it will be my most favorite thing as I age and as I, potentially change my location to one of the facilities that we're speaking to in the future. So I'm going to refresh, and then I'm going to. Here we go. So sleep is important. Humans need 4 basic things in life to live, to sustain ourselves. And listed here are oxygen, water, and food, which is probably evident to all of us, but we also need sleep. Humans deprived of sleep will not survive, period. So what is sleep? Sleep is a rapidly reversible state of reduced responsiveness, of reduced motor activity, and our metabolism also slows down. Sleep is observed in all animals, and the fact that it is preserved, that function is preserved in all animals, suggests that sleeping has some type of an evolutionary advantage and relevance. So why do we sleep? Well, we're not quite sure, actually. We know that sleeping generally restores us. We know it also conserves our energy because our metabolism goes down during the time we are asleep. And more importantly, this most recent function has been known for maybe a couple of years, maybe 5 to 10 years. We consolidate our memories of what happened in the previous 24 hours while we are sleeping. That's when our recent memories that we learned throughout the day, it goes into our long-term memory at that time. So if you have students who are staying up all night to study, tell them not to do that. It's better to study and then go to sleep, and then that information will be there when you need it. So sleep and aging, let's talk about that. We know sleep changes as we get older. And these have been well studies. Have been studied a lot. So what kind of changes do we see? We see a decrease in our total sleep time. So those individuals who are used to sleeping 8 to 9 hours a night may actually go only to 7 or 8 hours a night. We also have a latency. Latency means time to get into a REM. REM stands for rapid eye movement sleep. So we have an increased time to get into our state where we are dreaming. Dreaming occurs during REM sleep. And we get into REM sleep after we go through a series of what we call deep sleep stages. So we have a decrease in deep sleep, which means we're having a harder time getting into actual REM sleep, which is the restorative sleep. We have increases in the time to get to sleep from the time your head hits the pillow to the time your brain actually goes into sleep. We have increases in daytime napping, possibly because we have more difficulty with nighttime sleep. And we also have increasing wakeful periods while we are asleep. So we go to sleep but then we wake up. We go to sleep and then we wake up. So what this does is that results in less time in REM sleep, which is the refreshed restorative sleep. So the question is, are the cards stacked against us as we get older? Well, not really. Yes, there are changes in sleep with aging, but there are also lots of other reasons that we are having more trouble sleeping. So we know that with life changes, that can impair our sleep, such things as retirement, obviously illnesses, worry, pain is a big one as well. But however, we also know that our own poor habits can impair sleep. So, for instance, if you spend long periods of time in bed while you're not sleeping, well, then your brain gets used to not sleeping while you're in bed. So such things as reading in bed, not particularly good for your sleep, and certainly watching TV as well. If we go to bed and we try to force sleep, that's not going to happen. That's a real problem. If you develop into an irregular sleep schedule, so if, for instance, if you're on like swing shifts and you have to do shift work, you get into irregular sleep patterns. And that's not helpful. Use of any type of stimulant, and this includes our caffeine, our nicotine, and alcohol as well. If there are stimuli in the bedroom environment, that tends to wake us up, and so then we have less consolidated sleep. I had a gentleman in clinic the other day who keeps the cat in the bed with him, and the cat sleeps all day, and then the cat's up all night. And the problem is the patient's up all day and wants to sleep at night, so that doesn't happen. So any kind of stimuli in the bedroom environment needs to be taken care of. If you're worrying a lot at bedtime, if you're having some either health challenges or family issues, sometimes people worry about politics at night. Well, that's really not the time to do it because you're not going to be able to get to sleep. If a person has lack of exercise and you're not particularly tired because you're not physically tired, you're going to have a little more trouble getting to sleep. And certainly if you have frequent daytime naps, you know for certain that you are going to have more difficulty getting good consolidated sleep at night. So here's one of my cartoons. So a woman is enjoying a cup of coffee, and her husband is saying to her, I have a theory about your insomnia. Okay, so we're going to talk a little bit about caffeine, but just one slide on caffeine. We know that caffeine is the world's most widely consumed psychoactive drug, if you will. It is characterized as the central nervous system stimulant, so it wakes us up. It wards off any drowsiness, and halfway through our afternoon, we need that cup of coffee to keep us going through our workday. So caffeine is consumed daily by 90% of adults in North America. So this is a widespread habit, if you will. A lot of people think caffeine is just in coffee, but it's also found in tea, soft drinks, energy drinks, and also pills. So if you have a beverage and it does not say caffeine-free, then you should assume that there is caffeine in that beverage. And that applies to soft drinks other than colas, and it applies to tea, even if they're green tea. Unless it says caffeine-free, you can count that there is some caffeine in that tea. Now, the effect of caffeine on sleep is highly individual. So I used to have a girlfriend in college who used to take a cup of coffee to go to sleep at night. Well, that's not me, so we have to understand what our own effect of caffeine is. And generally, the issue with caffeine is people will say, well, I only drink it in the morning. The problem is that as we age, the metabolism of caffeine slows way down, and that cup of coffee that you had at 8 o'clock in the morning, it can still be in your system 8, 10 o'clock at night, even midnight. So it sticks around a lot longer than what you can imagine. And so my recommendation is, if people are having trouble sleeping at night, we need to taper and get rid of all caffeine for the whole 24 hours. So let's move on to another, if you will, medication, that of alcohol. So alcohol is often thought of as a stimulant because, you know, we take a drink, we're in a social environment, we feel, you know, happy and energized. Well, the fact of the matter is that alcohol is actually a depressant. It depresses brain function. Hence the term nightcap. You probably have heard that term before. So the nightcap, alcohol can induce somnolence because it is a depressant. However, once the effect of the alcohol is it wears off as the drug is metabolized, the brain rebounds and the brain is activated now because the depressant effect is no longer present. So what ends up happening is the brain arouses, and we can see this on brainwave tests. When the brain arouses, then often the individual will wake up, and then you have variable ability to actually get back to sleep. So general recommendation in the elderly and in us too, if you're having early morning awakening, we're talking 1 o'clock, 2 o'clock, 3 o'clock in the morning, stop your alcohol use. That's one thing to do. And certainly, if you have any kind of insomnia, don't use alcohol as a nightcap, if you will. So that's my talk on alcohol, but I could go on forever. So let's move on to nicotine. Nicotine is a stimulant, as we know, and we get nicotine generally from tobacco use, either smoking or with chewing, but you can also have alerting response from a replacement, like a patch, if you're on nicotine replacement therapy. This can cause insomnia. So generally, people who are withdrawing or want to come off of cigarettes, they use the nicotine patch for up to 18 to 20 hours a day, but then they take it off because you need to get to sleep. So the half-life of nicotine itself is only 1 to 2 hours, but here's the hitch. Nicotine has an active metabolite. So yes, you take nicotine in, the liver metabolizes it after an hour or two, but it metabolizes it also into an active ingredient. So you've got that nicotine effect in your blood for up to 24 hours. So again, the recommendation, if you have insomnia and you use tobacco, stop using the tobacco. If you have early morning awakenings, definitely also stop your nicotine use. And personally, I do not see any good reason why not to recommend stopping nicotine, period, because we know it's not good for us. So sleep impairment, how about illnesses? Well, there are a lot of illnesses that are associated with poor sleep. And this doesn't mean only when you're older, but also when you're younger. So here's a list of illnesses that contribute to poor sleep. And of course, the big ones definitely are anything that makes us uncomfortable, excuse me, uncomfortable. So such things as arthritis. If you have chronic pain from any cause, if you have restless legs, or if you have something called what we call periodic leg movements of sleep. Medications can also contribute to poor sleep. So there's lots of health issues why we have sleep. So it's important to go through this. And you'll notice here that I have highlighted dementia. Things get changed. The brain changes as dementia develops, and it can impair sleep. So what to do for sleep, for insomnia that's associated with illness? Well, our clients, our patients need help in helping them analyze why they're waking up. Are they having shortness of breath at night? You know, you lay down flat, sometimes you're mobilizing fluid from your legs, it's going to your lungs, and you're going to get short of breath, and you're going to wake up. So we have to adjust medications. If you're going to the bathroom, if you're waking up a lot to go to the bathroom, again, we can restrict medications. after the dinner hour or perhaps even earlier, so that extra fluid is not getting into the system, which then needs to be eliminated. If you're having pain, I'm going to talk a little bit more about pain. There are medications. There are also relaxing non-medication techniques that we can use, such as massage or heating pads. Of course, if you're having a chronic cough, we can use a cough suppressant, of course. Restless legs is an actual medical diagnosis, and believe it or not, that might be tied 100% to iron deficiency. Something about the brain metabolism of the iron in the brain can make us restless, and when we try to go to sleep, we get the restless legs. So that's one thing that we always check. A simple blood test for an iron level will help determine if a person is iron deficient, and that's an easy fix. We can supplement the iron. Individuals who have lots of worries, if they're depressed or anxious, a psychological therapy and also use of medications can also help them sleep better. Insomnia can be also from medications. We need to take a lot of our medications in the morning and not necessarily at night. So there are some of those medications that can be moved from the night to the morning, and I have a few suggestions for that in the next couple of slides. Are you having vivid or disturbing dreams, otherwise known as nightmares, that wake you up? Then we have to examine your medications to see if those medications are causing nightmares. And there are some medications that do that. So that's an easy fix. We either get rid of the medications or we move them to the morning. So after we determine the cause of arousal from sleep, we have to target those precise symptoms. It's almost as if we're on kind of a investigation, if you will. We're a detective, and we're really trying to understand why people are waking up at night. So these are a list of the common causes. I also want to mention beyond the psychological symptoms of anxiety and worry. Sometimes people are fearful of darkness. Sometimes there's a panic at times. And if you happen to have a little bit of suspiciousness, either as a personality trait or perhaps paranoia as a symptom of a medical diagnosis, we need to recognize that, because those feelings are much more going to come out at nighttime than they are during the day. So again, a little detective work can help us identify why our patients are not sleeping very well. So another favorite thing I like to talk about, stimulus control. We all know Americans are overstimulated as a baseline, and we often will take all of that into the bedroom with us. So basically, the recommendation is don't watch TV, read, eat, or worry while in bed. That's easier said than done, I understand. Use bed only for sleep, and no other reason. Again, I know that sounds a little cruel, but the bed has to be associated with sleeping and not anything else. It's important to try to wake up at a fixed time every morning. That gets the brain into the habit of sleeping and then waking up, sleeping and then waking up. Try not to wake up our patients for, I call them hygiene events. Obviously, a hygiene event would be, say, an early morning shower or bath, or getting cleaned up ready for a way too early breakfast, like 7 a.m. Obviously, if an individual is incontinent, then it's required that they become clean, and so that's a hygiene event that we really can't control, but we can try to, again, identify reasons why that is happening to the individual while they're trying to sleep. Again, a cruel, somewhat a difficult recommendation is not to take a nap during the day. And if a person does need to take a nap, which again is pretty common as we get older, do not allow our clients to sleep for hours at a time. A brief nap, a refreshing snooze is fine, brief 20 to 30 minutes, But if we're going on 2 hours, 3 hours, you know for certain the brain's not going to need sleep at night, so that person's going to be up. How about medications? So a lot of people take various medications to sleep. So you have to know there are 23 approved medications by the FDA. So that equals big business, and that equals big bucks. Many medications are used off-label. So we have over-the-counter medications that include PM medications, PM meaning you take them at nighttime. Most of those medications either include diphenhydramine, which is the generic name for Benadryl, or some modification of that. The PM medications are, they'll get you to sleep, yes, but they will also perhaps give a hangover in the morning. And for the brain, they're not good. There are a lot of herbal remedies as well, or folk remedies, including alcohol. Valerian is one that's often used. That's one of the most 10 top herbals used in this country. And we've heard a lot about melatonin in the past couple of years. Melatonin is one I'm going to talk about in a little bit more. So, medications. What are some of the side effects of medications? Well, there's that hangover effect. We medically call that daytime somnolence. If a person takes one of these medications, you can get excessive sedation at nighttime, so that if you do have to wake up at night and you're still sedated, you're going to perhaps have excessive confusion. These medications routinely cause cognitive impairment. You heard about the woman who got on the plane to go to London from New York. She took a dose of her usual sleeping medication. She got off the plane in London. She went through customs. She checked into her hotel. She went to sleep. And when she woke up, she couldn't understand how she got to London, right? She had a period of amnesia from the effect of that sleeping medication. Sometimes we have nighttime wandering. Balance problems are huge. Almost all of these medications are labeled as a high risk for falling. So that's very important to know. And then if you fall, you also have fractures and or other injuries. They can add to agitation, delirium, motor incoordination, slurred speech, lightheadedness, etc. So these medications are not innocent, innocuous, safe preparations. So that's why we're emphasizing non-medication solutions to insomnia. So here's another cartoon for us. So it's a woman asking for a sleep medication, but she wants something that's non-drowsy, right? Well, that's kind of an oxymoron, but what she's really talking about is, give me a medication that I can get to sleep with, but then won't make me drowsy throughout the rest of the day, okay? That's a huge request. So again, to harp on the medications a little bit more, the benefits are slight. The benefits, I wouldn't even describe them as modest. They're small. So if you take a medication to get to sleep, you can get to sleep about 10 minutes faster. I don't think that's not clinically important. Your increase in your total sleep time will only be 30 minutes. And these medications do not induce the restful REM sleep. They might get you into sleep, but it might be stage 2 or 3, but it's not going to get you into that stage 4 restful sleep that leads to REM. So yes, you sleep a little bit more, but it's not the restorative sleep that we need. So compare those benefits to the harm that these medications give us, and basically a 4.5 time increase in death. I mean, how far will we go for a good night's sleep, right? To increase your risk of death up to 4.5 times is really too much. So that means four extra people will die per 100 over a 7-year time period. So the safest, you can see where I'm going, safest is non-medication treatment. So this is my own recipe, okay? Please, when I check into your facilities, I want a dark, quiet, and a cool environment to sleep in. I would love for you to give me a glass of warm milk off of the refreshment cart before I go to bed. I want you, and now this, you'll have to take me at my word on this. I want you to not give me caffeine, alcohol, or nicotine, because I love my sleep more than any of those things. At bedtime, if a person is not successful with those steps, offer or prescribe melatonin. Most people start at 3 milligrams, but sometimes even a 1 milligram tablet will work. I wanted to make the connection also between that warm glass of milk and the melatonin. So the warm glass of milk has the building blocks of proteins are called amino acids. There's one amino acid in milk that's called tryptophan, and in the brain, tryptophan is converted directly into melatonin. And so a warm glass of milk can sometimes work as well as the melatonin. So it's that pathway in the brain that allows us to get to sleep, and melatonin is a neurotransmitter that helps us get there. Also, if I've been exercising too much, I might have a little soreness at times. And so I want you to give me some Tylenol. I want you to give me a 500 milligram tablet of Tylenol when I go to sleep, because I know then that all of my aches and pains will be a little better controlled and will not wake me up. So please do not treat my insomnia with medications. I'm pretty sensitive to medications, so you're going to give me a morning hangover, which means, yeah, I'm going to go to breakfast, but then I'm going to go back to sleep again, right? And then that evening, I'm not going to be able to get to sleep when it's the regular time. So, and then the last recommendation is no nighttime vital signs, and please don't give me medications after 5 o'clock. So let's talk specifically here about dementia, and I've already invited myself back to give another talk more specifically about sleep disturbances affected by specific brain diseases. So Shannon, I've just invited myself again. Oh dear.
We're happy to have you.
So the last slide here. What can we specifically do with individuals with dementia? Well, many of our people are on dementia-specific medications, and they're listed here: donepezil, galantamine, and also rivastigmine. That rivastigmine is often the patch. It's recommended often to give these medications at nighttime, but there's no medical logic for why we have to give them at nighttime. We can move those medications to the morning. And the reason it's important to move them to the morning is because these medications, they work on the brain, and they can sometimes cause disturbing dreams. They can sometimes cause vivid nightmares or vivid uncomfortable dreams. So please, as a rule, I would say do not give those medications at night. You can put them into the morning. Also, again, a general principle that we've just talked about is please minimize sleep interruptions at nighttime. If somebody comes in and wakes you up and you've been sick or you're on medication, you may not initially understand where you are. And if you already have a dementia, that could potentially be an increase in confusion if I keep getting woken up all the time. If I'm still sleeping in the morning, please let me sleep at least until 10 o'clock. Certainly don't wake me up at 7 or even 8. If I'm sleeping, let me sleep, and then wake me up at a reasonable time, whatever, 10 o'clock, and then keep me active throughout the whole day, and then I'll go back to sleep very nicely in the evening. If somebody has totally flipped their sleep-wake cycle, we're going to have to gradually over time get them back into the habit of sleeping at night and being alert and active and engaged during the day. And then my last point here is specifically for persons with Lewy body dementia. A lot of the behaviors with Lewy body come out associated with sleep cycles. So many individuals will start off the evening by getting a little bit of sleep, and before you know it, they're up and awake, and they're having all the hallucinations, because the hallucinations are actually dreams. It's part of that sleep cycle that is disturbed because of the Lewy body. So what we need to do is vigorously treat the sleep disorder, especially in Lewy body. And the specific medication actually is melatonin. And if high doses of melatonin given on a regular basis with good sleep-wake cycles does not help, then we have additional medication that we can add on. But I can tell you the additional medication is not an antipsychotic. The additional medication can be a low dose of a benzodiazepine called clonazepam, and clonazepam is also specific for the Lewy body dementia. I have to say, do not use antipsychotic medication to treat Lewy body patients. And you'll notice here on the slide, I've actually said antipsychotic sedation, because the antipsychotics, the effect of the antipsychotics is to sedate the person so they can get to sleep. But it's a non-specific effect. We're treating that sleep disorder with antipsychotic medication, and it's not the correct thing to do. We need to try the melatonin in escalating doses, and we also need, if possible, if needed, to use additional small doses of clonazepam to supplement the Lewy body. And again, I talked about this last month, but again, just to emphasize, the people with Lewy bodies represents a specific, special, different case, and they need to be treated appropriately. So I think that was my last slide. I'm sorry, I've totally monopolized this conversation. Now it's your time for some questions.
Okay, we have a couple of questions in chat already, but if you could think of anything as we're going, please go ahead and enter them there. If you need to go back to your day, we totally understand, and this part will be recorded and posted to our website, but please stay on if you can join us for a few. We have a question on obstructive apnea and treatment options for elders.
Whoa, that is a great question. I didn't even talk about obstructive sleep apnea. So the issue with obstructive sleep apnea is that the brain is never getting into the deep sleep. The brain in obstructive sleep apnea, believe it or not, is waking up sometimes as often as every minute. You cannot get deep sleep, refreshing sleep at all if you're waking up frequently because of obstructive sleep apnea. There are a number of treatments that we can give. In general, we have to stay away from sedating medications, which includes alcohol, but again, probably not too many of your clients are having the alcohol. But if we can go through the medication list and remove the ones that cause sedation, we're going to help that sleep apnea. Some individuals with sleep apnea are what we call nasal breathers. They breathe through the nose, and if you're getting obstruction through the nose, you can have difficulties. So they have the nasal strips that can be used on a routine basis to just literally kind of, if you will, butterflies open the nasal passages for some people, and that can be very effective without having to have the full positive pressure breathing machine. Sometimes individuals will be able to sleep very soundly if they're on their side versus on their back. And believe it or not, they sell on the internet, you can get these night shirts that have beads sewn into the back so that the individual won't lay on their back and snore, and that's what causes further symptoms in sleep apnea. So again, try to get the individuals to sleep on their sides and avoid sedating medications, maybe use some of those nose strips. In general, the best treatment is documentation of adequate sleep with the use of the CPAP. And that involves a lot of difficulty with masks, as well as the pressures from the machine. So that's an out of facility solution. The individual has to keep going back to the sleep medicine clinic to get that squared away. So I'm sorry, that's not an easy situation, but those are some preliminary suggestions for you.
Great. Thank you, Dr. Knoefel. I want to comment that we posted a link to some resources on sleep hygiene in chat, and Janelle had mentioned how much, let's see, she said the Restorative Sleep Vitality Program checklist is awesome. So if you're not familiar with that, please go ahead onto our website via that link for some more information. We had a question about, what about residents who are bedridden and watch TV, eat and read, etc. in bed?
And my question back would be, can they not be go into a wheelchair at times? Can they go into a recliner, perhaps in the activity room? And can they be in what we call a semi-sitting position? So that's when actually I would get your OTs involved, occupational therapists involved, because they might be able to modify some of the chairs and the seating positions to make the individual more upright. That's a difficult one. So I would say have a team meeting about that problem. And see if we can somehow find a way to really engage that individual and keep them out of bed, out of the room, and into the activity room, perhaps in another type of a chair or a recliner.
And then we had another comment from the same person mentioning they have a resident who requires Ativan to leave their room for a shower and has panic attacks whenever they're taken from their room.
I would say, and you're probably going to be smiling at this answer, but there's no simple solution to that situation. We have to make a differentiation, I believe, between an individual who is actually having panic attacks versus an individual who has dementia and is resistant to care. And in some instances, people who are resistant to care can very successfully go through a hygiene event with a little bit of an Ativan pre-treatment. So that's a different situation. If this individual is actually having panic attacks, that is indicative of an underlying anxiety disorder. And we can treat anxiety disorders with a number of different medications, including routine SSRI antidepressants. There are a number of other types of antidepressants which can also be used. So I would say that, again, getting a psychological evaluation on that individual, perhaps finding out what works in the past. But in general, as you know, we try to stay away from the benzos. The benzos, they have an effect, and then the effect wears off and the person gets more anxious, and then you give more medication, and then the effect works, and then it wears off again. So you're kind of on this little bit of a roller coaster. But the antidepressants in general work more across the board. They're more stabilizing over time. So I would, for that individual, I would say, get a professional involved, and with the suggestion of maybe treating and with a different strategy, maybe an SSRI or SNRI antidepressant is what was where I would go with that situation.
Great. Okay, such good questions, and I really appreciate this, but I also want to respect everybody's time and need to get back to their day. So I'd like to just make a quick announcement, which is that this presentation is going to be posted to our website in a few weeks. I encourage all of you to check out every posted webinar we have there in our nursing home library, and I've put the link already in chat. If you are not sure where to locate it, just go ahead into chat and you can click on there and find a wealth of resources. And please share with any of your colleagues who couldn't attend, and we will have this posted so you can use it again for training and in-service purposes at your convenience. So again, for New Mexico teams, if you haven't already done so, please make sure your name and all attendees are represented in chat so we can send you a CE test link early next week. And our next hot topic will be coming to you in December. I would like to thank our presenter, Dr. Janice Knoefel, for a great presentation again, and thank you for your willingness to come back. We'll take you anytime. So, thank you all very much. We appreciate you for being here. Thank you, Dr. Knoefel, and everyone have a fantastic Friday. This is the conclusion of Hot Topics. Enjoy your weekend.